This is the cool kids table. Oh, you did? Is she the athlete? No? Oh, she horseback rides. Oh, I'm jealous.
Good morning, everyone, and welcome to our Review and Renew Sedona Conference. My name is Jessica Richter. I am a program coordinator at Total Health. We are so happy to have you all here to participate in this special and unique oncology conference. The meeting this weekend will serve as a valuable forum for the presentation and discussion of new research findings in oncology education. This meeting was created in 2022 with a very intentional spirit, pairing oncology education with a unique opportunity for renewal, presence, and connection. We imagine this to be kind of a retreat wherein meaningful oncology updates could be shared in a more relaxed environment. Before I welcome our first speaker and we get started with our first discussion, I would like to review some housekeeping items. In front of you at your table, you will find the meeting program guide that contains the Wi-Fi information, non-CME sessions, and CME information. If you are sitting in the back two tables of the room, there are no program guides on those tables, and we would encourage you to move up and forward to another table.
It's intentional.
I encourage you to download the conference app for the weekend. To do so, please go to your app store and download the Cvents app. Once you have the app downloaded, please search 2025 Oncology Clinical Updates Review and Renew Sedona and select the event. Once you are in the event, you will be prompted to log in using the email you registered for this conference with. After you are logged in, you will have access to the agenda, slide decks, speakers, exhibitor information, and information on CME and CE credit and mock points. We have an exhibitor bingo raffle going on for the weekend. If you did not pick up your raffle sheet this morning, please head over to the registration desk and pick one up. You can use the sheet to go around the room for the exhibitor booths and get signatures, and then you'll turn the bingo card back into the registration desk, and at the end of the day, we will announce the winner. The winner will receive a digital gift card, so we encourage you to do so, and that's a great tactic for mingling with all of our exhibitors. We have some great sessions planned this weekend and encourage you to share your thoughts and questions throughout the presentation. If you have a question, please raise your hand and I will come from the back of the room with a handheld mic so that everybody can hear your question. For those of you who signed up to participate in our Jeep Tour excursion this afternoon, please visit the registration desk and sign your waiver. You're not allowed to get on the Jeep without a waiver, so we do have to have them signed. If you did not sign up for the Jeep Tour and you are interested in attending, we do still have a few slots left, so also please visit the registration desk and we can see if we can get you signed up. Lastly, if you need any assistance throughout the meeting, please find a member of my team at the registration desk or myself at the back of the room. We are all in black and would be happy to help you. Our first speaker I would like to invite is Sammy Mansfield from Cancer Wellness for Life. Sammy will share some lifestyle tips and strategies, and I encourage you all to participate in her fun presentation.
Encourage participation. Good morning. Oh my gosh, that's where we're gonna start? Good morning. Oh, thank you. So 30 years ago, I was a group fitness instructor, and I would put people in a movement pattern until they said things loud enough for me to be satisfied that they were suffering. Fair enough? So there's a punishment. No, I'm totally joking. I'm Sammy Mansfield. I'm excited to be here at Total Health. I've been working with Total Health for many years, probably 5 now, delivering education and being part of these conferences. Not only do I get to learn, but I love to learn from all of you, so I find this to be fuel for my brain. I'm here in a couple of capacities this weekend, and my biggest capacity is to bring you lifestyle strategies as an individual. So during my sessions, I encourage you to think about selfish thoughts of where you can take in ideas for you. And so that's really what I'm gonna be focusing on in today's, or in this weekend. And also I tell people I'm happy to be a little bit of your coach. I am not the food police, fair? I am not someone that's gonna make you do certain things, but at the end of the day, I want to be here. If you have questions, just grab me, I'll be here throughout the whole weekend, okay? So as we start, I always wanna start with what is it I'm gonna be really focusing on with lifestyle. So I'm part of an organization, many of you might be familiar with this organization, but many people aren't, called the American College of Lifestyle Medicine. In the American College of Lifestyle Medicine, there is a very prescriptive approach to lifestyle. However, I want to really take a simplistic approach to this, understanding that lifestyle really is about habit change. It is about the things that we can do, maybe the things that we can avoid to live better, live longer, live stronger, be happier, have better health, mental health, etc. Here are the 6 pillars. On the evidence side of the pillars, we have the most evidence in nutrition, exercise, and reducing unhealthy habits. This is where the science is for us as humans, as well as our patients. We have 3 other pillars: stress management, sleep quality, and social connections, that are good for us, but really don't necessarily have the science. And I like to differentiate that here at Total Health. In a lot of the conferences that I do, I don't want to tell people if you do have a solid stress management habit that you're going to reduce your risk of chronic disease, but we know it's beneficial for us as well. This is a very busy slide, but I threw some data up here. Why is this important? I think one reason that being part of lifestyle is important is that it's a tool for us for self-care. Because when we practice certain things ourselves, we tend to influence those in the things that we do in our life. How many of you know that if you want to participate in an activity, it's nice to do it not always by yourself and have people that support you? This goes both ways, my friends. This is the people that are like, let's go have the donut, right? You all are quiet. Do we need to get up? Does everyone have coffee? All right. I'm trying to, this is going to be a long day, so we're going to have some fun. All right. Fair enough. But I want to stop and say that we know, especially in healthcare, that individuals that have found strategies for self-care report better satisfaction, they report better mental health, they report better sleep, less burnout, not because the system always gets better, because we're more equipped to handle the stressors of the system, AKA life. So I want to tell you that I believe that these principles build our toolkit of lifestyle that you can then take into your life and pull those tools out when you need it. How many of you know that we have these toolkits, and then once in a while, the imaginary toolkit, you pull out this thing and went, I forgot about that habit. And we did something, and then for whatever reason, it fell out. And so this is the thing that I want us to think about this weekend throughout our time together. So what are the barriers? How many of you can think of 700,000 time? People. Don't feel like it. I'm tired. Misinformation. I love this one. Somebody said to me, like, do you do TikTok? And I was like, no, because it's like distracting, right? There's a lot of great information out there, but there's a lot of things out there that are misinformation. So throughout this weekend, here's what we're going to be doing. We're going to be focusing on changing our thought process and our actual time, because this creates space for us to implement lifestyle. So we have a lot of amazing speakers lined up for you this weekend that are going to give you a lot of solid clinical information. My role for you is to take space throughout the weekend for you. So this will help you retain and learn information, but it will also create a way that you can implement self-care. I want you to leave this weekend with a bit of a toolbox, of a refresh, or maybe some new tools that you can take back with you on Monday. Fair enough? What? Yes. Whew. I am definitely patient. We'll get it. All right, so we have a renewed agenda for you. Why not? Because we're at the renewal weekend. So one of our speakers this morning, Sandy, is unable to make it. I know she has food poisoning, and that just doesn't seem like fun. So I'm going to be stepping in, and rather than have that piece that you'll see on your agenda, you will come back at 10:10 or 10:50, excuse me, with me. So one of the things that we're going to be talking about is starting with the pillars of nutrition and exercise, understanding what they mean, how they're important, and what to do about them for the rest of your day. We'll talk a little bit about lunch, because I want you to feel good fuel, plus the Jeep tour. We need fuel for that. And then, of course, this afternoon we'll do a movement break, and then you'll see me back again tomorrow. So just giving you a refreshed agenda. Fair enough? Are y'all ready? Yes. Buckle up? Yes. Woo! All right, now we're ready. Okay, I'm passing it off to my next speaker, Jessica. You good to go? She's like, I'm back. All right, oops, leave the clicker. Always leave the clicker. Thanks, everybody.
I would like to invite our next speaker, Dr. Schwartzberg from Renown Institute for Cancer, up to the podium. Dr. Schwartzberg will present our updates in breast cancer.
Morning, everybody. It's a real pleasure to be here. I'm going to give you some updates from the San Antonio Breast Cancer Symposium, and before I start, I want to tell you a little bit about this meeting because it's a very special meeting. I've actually been going to San Antonio for the last 30 years. It's almost 50 years old, and it started in San Antonio with a visionary breast cancer doctor at the dawn of, one could say, of the initial treatments of breast cancer with endocrine therapy. And it's blossomed to the biggest breast cancer meeting in the world. This year, about 9,000 people attended. I started going 30 years ago when it was in a small ballroom in the Marriott, and now it takes up the entire convention center in San Antonio. So it's a place that, because it's a single type of cancer meeting, it includes the entire spectrum of people working and thinking about breast cancer, from basic scientists, translational scientists, to surgeons, to radiation doctors, to medical oncologists, to advocates. Advocates are a big part of San Antonio, and everybody gets a chance to interact. And because of that, it's really a holistic meeting. So today, I'm actually going to give you some of the highlights. One of the things they've done for the last few years at San Antonio is, at the very end of the meeting, they have a session called View from the Trenches, What to Do on Monday Morning. So that's what I'm going to do here, adapt that for you from what I think you can take home on Monday morning and use in your practice. So I'm going to divide this up into 4 sections: local therapy, early breast cancer treatment, metastatic breast cancer treatment, and then, especially since we're here in Sedona and we're focusing on ourselves as people, what about the patient-centered approach, which is really so important. So the first thing I want to talk about is local therapy. And by local therapy, I mean surgery and radiation treatment. The theme over the last few years, because thankfully we've been doing so much better in early stage breast cancer, is that we've been able to focus on what's called de-escalation. In other words, can we preserve the benefit of the treatments that we have, but reduce the toxicity by doing less but maintaining the benefit? And in general, in cancer treatment, and as we design studies, whether it's surgical or medical oncology, we start with a more aggressive approach because we don't want to leave anyone behind who might benefit. But once we get to a point where most people are benefiting, the question is, can we maintain that? So the first study I'm going to talk about is called the Encima study, and then the Supremo study. So Encima was a surgical study. So one of the things we've done for the last about 25 years is do sentinel lymph node biopsies. I'm old enough in my career to remember when women had radical mastectomies, or at least total mastectomies and axillary dissections. And that means taking out all the lymph nodes that the surgeon can find. And then we moved to sentinel lymph node biopsy, which became the standard of care. And now the question is, can we go beyond that? So in Encima, they randomized women to get either sentinel lymph node biopsy or no sentinel lymph node biopsy if they had early stage breast cancers, stage 1 breast cancers that were node negative, and they had planned breast conservation studies. So here are the results. The invasive disease-free survival was virtually identical at 5 years of follow-up for those patients who had no sentinel lymph node biopsy and sentinel lymph node biopsy, and it met the planned parameters for this study. And here's the overall survival. So remember, this is stage 1 cancer patients, and they're doing extremely well with over 95% survival at 5 years. And of course, this is overall survival and not necessarily breast cancer specific survival, which would be even better. So very, very few women are relapsing in this setting, and they had less surgery. And so this becomes a new standard. So in this particular study, the conclusions of the authors was there was not an inferior outcome from omitting sentinel lymph node patients in sentinel lymph node biopsy in certain patients, and this de-escalation concept is suitable for the patients who met the criteria for the study. It adds to a body of data that has shown this before in older women. And so this is a new option for women to discuss with their surgeons and their oncologists if they have a stage 1 HR-positive, HER2-negative, low-grade cancer. The next study was also a de-escalation study looking at whether we need to do post-mastectomy radiation in what we call intermediate risk breast cancer. And this has been an area of great controversy over the years because early data based on our less efficient and regimens from the past showed that there was some benefit both in local recurrence and also overall survival in giving radiation therapy to the chest wall after a mastectomy. And that this study looked at that question. The primary endpoint was overall survival. These patients were randomized to no radiation versus the standard radiation. And again, if you look at these curves here, you can see virtually no difference in overall survival. In this case, 10 years of follow-up, and you do need long follow-up for these patients to see if there's any benefit. These patients may have an event after 5 years. In fact, frequently have events after 5 years. So 10 years is a good landmark to see what the long-term outcome will be. And you see no difference here. This is chest wall recurrence. If you look at these curves, there's really no difference. Overall, there was less than a 2% risk of chest wall recurrence in patients who had radiation, and that could be handled locally. Here's the regional recurrence, including both chest wall and the axilla, and there was no difference here, as you can see. No significant difference. And importantly, in metastatic and disease-free survival, no difference as well. So the conclusions were for patients who had 1 to 3 positive lymph nodes or N0 with other risk factors, adjuvant chest wall radiation did not improve 10-year survival, a clinically insignificant reduction in 10-year chest wall recurrence at less than 2%. No impact on disease-free or metastasis-free survival. And why is this? I mean, why can we omit this? This was canon for many decades. It's likely because we've improved the multidisciplinary care of our patients in multiple directions in terms of imaging and finding lymph nodes and finding disease, and the fact that we, of course, treat them differently with endocrine therapy, chemotherapy, and targeted therapy when we need to. So the conclusions from this study is that adjuvant chest wall radiation can be admitted in most patients who meet the eligibility criteria for the study, which was called Supremo. So that's 2 very important landmark trials that suggest we can do less and have the same outcome, and that means less morbidity for our patients. Now, it is true that the morbidity is not particularly high necessarily from radiation, especially compared to something like chemotherapy, but there is morbidity. There's fibrosis, there's pain, and so forth. So our goal when we treat cancer patients is the ultimate goal is treat them, cure them, and have no long-term toxicity. And we're getting closer in breast cancer to those goals. So now I'm switching to adjuvant therapy that we use after local therapy. And there's a couple of questions here that were addressed and I think raised some interesting new ideas about how we can do this. The first one is using genomic assays, which we've used for 20 years to make a decision about chemotherapy or not. The question is, can we decide what type of chemotherapy we need? Do we need aggressive chemotherapy with an anthracycline, which, as you know, very old drugs we've been using for 50 years, but do have long-term toxicity, and increasingly we're seeing some late cardiotoxicity from anthracycline. So a couple of studies that helped us decide that, and also in one case escalating therapy in patients who are high risk with in a specific molecular subtype, which are those that have germline BRCA mutated patients and high risk features, and I'll show you the long-term data on that. So this issue about anthracyclines has been with us for a long time. We've addressed it with clinical trials that haven't been clear in patients with HR-positive, HER2-negative. We still don't have prospectively designed trials, but what we do have, and was presented at San Antonio, was this retrospective review of a pivotal trial called TAILOR-X, which used the 21-gene assay to help us determine whether or not patients would benefit from chemotherapy. And this was a post-hoc analysis looking at patients who got either anthracycline-containing regimens or non-anthracycline-containing regimens to see if we could ferret out who benefits. And it turned out that the recurrence score, if you're not familiar with it, is a score which goes from 0 to ostensibly 100, but 0 to 50. And the higher the score, the higher the more likelihood of benefit from chemotherapy. And we typically use a breakpoint of 25 for chemotherapy in patients with node-negative disease based on this TAILOR-X trial. So they went back to this study and looked at what cut points showed benefit from anthracyclines, and it turned out to be 31. That's a pretty high cut point. We don't see that in a bunch of patients, but we almost virtually always recommend chemotherapy in those patients. And you can see that if you do get to a recurrence score of 31 or greater, that there was benefit from adding anthracycline or adriamycin, as you see in the right here, the TAC group versus TC. Most other patients get a taxane and cyclophosphamide as a standard program that's been around for a long time. So that turned out to be a 5-year benefit in distant recurrence-free interval if patients had a recurrence score of 31 or greater. So I think that was helpful. One interesting thing in a subgroup analysis was most of that benefit was in the premenopausal women, as you see here in this analysis. So it is a subgroup analysis of a sort of an ad hoc evaluation, so you have to take it with a little grain of salt. But although the postmenopausal women did show a hazard ratio that was statistically significant, the overall benefit was 2%. And, you know, we often struggle, or I often struggle, with a 75-year-old with a high recurrence score. Am I really going to give them anthracycline? And based on this, my personal opinion would be no, but I would definitely recommend it for premenopausal women who have those scores of 31 or lower, or, you know, younger postmenopausal potentially. I want to comment that this was not the only study that looked at genomic assay. Actually, just a few months earlier, we have similar data from a similar type of analysis from a registry study using the 70-gene assay, the MammaPrint assay, and here you can see that high 2 patients, again, it's sort of a continuous scale, and those patients that fall into that category of the highest risk, just like the 21-gene assay, highest risk, are the ones that seem to benefit, in this case called MP high 2. Those are the ones that seem to benefit. This is 3-year data, so a little shorter period, but you can see the big and small numbers, but at least directionally, it looks the same, that those that are in MP high 1 don't get benefit from adding anthracycline. Those that are in MP 2 do get benefit. So this is something that doesn't have level 1 evidence, but I think it is helpful in helping us make those decisions. The Olympia trial was a study that's been presented and published several times before, but here we're seeing the long-term outcome of Olympia. So one of the concepts in adjuvant breast cancer is stratifying women into low risk, intermediate risk, and high risk. For the high-risk patients who were BRCA mutated, about 3%, 2 to 3% of patients, whether they're triple negative or HR positive, HER2 negative, they were randomized to receive olaparib, a PARP inhibitor that is now approved in the adjuvant setting, versus placebo, based on the early results of this data. And they could be either triple negative or PR positive if they met the criteria which you see in the middle there. The primary endpoint was IDFS, and overall survival was also important. This is distant disease-free survival at 6 years, and you can see these curves separate, and there's really a substantial absolute benefit from adding olaparib to these patients with germline BRCA mutations. At 6 years, the rate is almost 8% difference, and if you get distant disease, as you know, you can't cure that for the most part. And here's the overall survival the ultimate criteria, which already shows at 6 years a 4.4% difference. So very strong data that indicates that olaparib should be offered to these patients. So the corollary of this is that we should be testing almost all patients, if not all patients, for germline alterations, at least in BRCA or any of the breast cancer increased risk susceptibility genes, because it has a meaningful benefit for them in survival. So just keep that in mind. You know, the NCCN guidelines have gotten a little bit less restrictive over time. I still find them too restrictive, but you should, if you ever have a problem with insurance, ASCO published guidelines last year which recommended all women over at 65 or all women who could benefit from therapy, i.e. Olympia, should be tested. So take that to your insurer when you do the most fun thing in our job, which is to an appeal against a prior auth. So that's the data here, and I think we've summarized that. Also importantly, there was some issues about whether we would see, because we're doing a PARP inhibitor and messing with DNA repair, would we see some secondary cancers? That was not seen here. So this is good data now to use and be practice changing. Okay, moving on to metastatic disease. I think there were 2 trials. I have 2 for each of these categories. So here, I think the top 2 were the Patina trial and the EMBER-3 trial, both of them randomized trials. So the EMBER study, I'll show first. This was a study looking at a new drug. So this drug is not available yet, imlunestrant, but it's very, very likely, based on this data, to be approved in the very near future. This was an interesting trial design because it had 3 arms, and it compared imlunestrant, which is a selective estrogen receptor degrader or downregulator, an oral drug that was looked at as single agent or standard of care compared to either fulvestrant, the previous SERD that we had, and or exemestane, an AI, and a third arm, which was combined therapy with imlunestrant and abemaciclib, CDK4/6 inhibitor. The patients who were eligible for EMBER had to be patients that had had prior therapy, and they either had to have advanced breast cancer, HR-positive, HER2-negative, and had progressed on our standard therapy, for most patients, AI-CDK, or they could have had adjuvant therapy with an AI and had early recurrence, which is considered primary endocrine resistance, with or without a CDK. And they compared, as you can see there, A versus B and C versus A. Importantly, what we know is that in these new class of oral SERDs, there may be differential benefit in those patients who acquire a mutation in the estrogen gene called ESR1. So that was a primary endpoint as well. Here actually is the results of imlunestrant versus standard of care endocrine therapy after prior therapy in the ESR1 mutation population. And as you can see here, it was statistically significant. The median progression-free survival was about a month and a half. Yeah, it was not huge, but you can see the curves actually separate beyond the median more, and the hazard ratio was 0.62, so 38% improvement there in risk of progression or death with an ESR1 mutation. Here's the imlunestrant and abemaciclib versus imlunestrant alone in PFS when you added the CDK, and the majority of these patients had received CDK inhibitor in the first-line setting. So here what you're doing is switching the CDK and switching the endocrine therapy to a new SERD. And here, this was a pretty substantial median progression-free survival from 5.5 to 9.4 months. Curves separate early, and then the hazard ratio was similar at about 0.57. So 43% improvement with imlunestrant and abemaciclib. The combination was safe as a single agent. These drugs tend to be pretty much the same as our standard of care therapy with fulvestrant as a parenteral SERD. And you can see there that grade 3 toxicity was uncommon as a single agent. In combination, as you see, mostly driven likely by the abemaciclib, diarrhea, and other GI symptoms, and non-symptomatic but lab abnormalities in hematologic parameters were the most common. So that will likely become a new standard of care for us, and I do recommend molecular testing in breast cancer has become very important. I like to do it at the diagnosis of metastatic disease because you can set up for what you're going to do in the second-line setting, but at no later than after first-line therapy, all patients should be tested with molecular profiling to see if they have an ESR1 mutation as well as other mutations that are actionable like PI3 kinase, AKT, PTEN, and so forth. So the next study is, I think, a practice changer as well. This was the Patina trial. This is looking at a different class of a subgroup of patients, the HR-positive, HER2-positive patients. We have many good therapies for HER2-positive, but we haven't really defined what the best endocrine partners are or what to do beyond using endocrine therapy in maintenance treatment after standard of care, which is induction with a taxane, trastuzumab, and pertuzumab. So in this study, they looked at adding palbociclib, CDK4/6 inhibitor, to continuation of trastuzumab, pertuzumab, and endocrine therapy after induction for metastatic patients with ER-positive, HER2-positive disease versus the standard of care, which was trastuzumab, pertuzumab, and endocrine therapy. And here are the results of the study. The progression-free survival increased to a remarkable 44 months. So that's almost 4 years from first-line therapy for HER2-positive disease, compared to the standard of care, which was 29 months, which in itself was respectable, and actually much longer than what we saw in the original pivotal trial, the Cleopatra trial, which established this strategy of induction chemotherapy followed by Herceptin and Perjeta. Let's see. Can you go back to a slide presentation? Oh, you got it. I have that. Okay. So this is secondary analysis of overall survival, so it doesn't show a survival benefit yet, and it may not, and that's because we have many good therapies now for HER2-positive disease. So I think you do run the risk of some toxicity, particularly as you would expect CDK4/6 toxicity, which is well known. We've been using palbociclib for over a decade now. So neutropenia, fatigue, there is a little more diarrhea. Trastuzumab and pertuzumab themselves cause diarrhea in some percentage of patients, so it's probably a little bit additive here. But given that very long progression-free survival of 44 months, I think this is a strategy that I came home from San Antonio thinking I'm going to use for my patients who fall into that. So here is the implications to clinical practice. So I just point out historically, I mean, one of the things about being in practice for many decades is I can look back historically. So I participated in the randomized trial that got trastuzumab approved in 1998, and that was a big climb. People didn't think that a monoclonal antibody had any role in treating breast cancer. We got the study done, and it was some machinations to get it done. So before 1998, the prognosis for HER2-positive breast cancer was terrible. It was about a year overall survival if you had a HER2-positive breast cancer treated with chemotherapy alone. Here's first-line therapy, which is 4.5 years. And given the drugs that have been developed against a very firm target, HER2, as an oncogenic driver in this population, I estimate that the median survival for these patients now is in excess of 8 years, probably closer to 10 years if you use every effective drug mostly. So that's a tenfold increase in 25 years in survival. It's a very meaningful difference for our patients. Okay, and the last thing I want to talk about is patient-centered practice-changing strategies. And I'm really proud of San Antonio and the program committee about emphasizing that not everything is about chemotherapy and or even surgery and radiation. It's about, as you heard from Sammy, lifestyle is important. and also taking care of symptoms of patients is important. And I'm going to talk about a couple of things that are, if not practice changing today, certainly should be in the very near future. So the first is about obesity and breast cancer. We've known for a long time that obesity plays a role in breast cancer, and that may be through endocrine mechanisms and estrogen metabolism. There was an analysis a decade ago from the early breast cancer study group looking at all the meta-analysis, in a sense, looking at all the studies that were done, and 80,000 individuals, and obesity was strongly associated with breast cancer in pre- and perimenopausal women who had estrogen receptor positive disease. And so here we see this large database, over 200,000 women from 147 randomized trials, of whom 26 met the criteria for obesity by BMI greater than 30. Most of them were postmenopausal. And here's the data, and it shows you it is a linear relationship between BMI and risk of distant recurrence here. And these are very large numbers of patients. So if you look at the right-hand portion, you can see that it really separates into those that are obese have a 17% improvement, 17% worsening of recurrence rate compared to women who are lean with a BMI less than 25. So for the recurrence goes up 6% for every 5 kilogram per meter squared. So this linear relationship was seen irrespective of patient or tumor characteristics, type of systemic therapy, year of diagnosis, or time since diagnosis. This is pretty powerful data that suggests a modifiable lifestyle can play a role here. And here's just some additional data. If you look at on the right-hand panel, pre and post, it both showed that benefit in this larger study. The absolute difference was more important for premenopausal women in terms of a 4% difference in node positive, 2% difference in node negative. It was about half that in postmenopausal. But this is still survival here, and this modifiable factor. So those conclusions were that overweight and obesity are associated with an increased distant recurrent risk. And although the substantial differences are moderate, there's slightly less effect in postmenopausal women. It's equally relevant in ER-positive and ER-negative early-stage breast cancer. So that's the background, and also presented as an oral study at San Antonio was the Be Well study. So this was looking at participants, over 3,000, who had stage 2 and 3 breast cancer, different subtypes, with a BMI greater than 27. And they were randomized to a strategy of health education and a 2-year telephone-based weight loss intervention versus health education alone. And the primary objective, which was not reported yet, was invasive disease-free survival. So a prospective trial looking at does modification of weight through using a strategy of counseling help. So we don't have the primary results yet, but we do have the secondary results, which are the biomarkers of weight. And that includes what happens to leptin, what happens to insulin, what happens to C-reactive protein and insulin resistance in women who were just counseled differently with telephone counseling. And these were significant changes in leptin, in insulin, and insulin resistance, and C-reactive protein out through 24 months. So this suggests that counseling made a difference metabolically, and hopefully we'll see if that makes a difference in outcome. So the Be Well weight loss intervention led to improvements in metabolic markers, insulin resistance, and inflammatory markers, and there was a physiologic effect of weight loss here, and we'll have to see about the outcome. So why is this important? Well, we're in a new era, and we have drugs now that will help us in addition to counseling. And those drugs are well known, I'm sure, to all of you today. Started with the SGLT inhibitors and now the GLP-1 inhibitors, which are really transforming things. So here's a poster that was presented from MD Anderson, 1,000 patients who were treated with GLP-1 receptor antagonists and their weight loss and patient outcomes. So they received semaglutide or tirzepatide in 38% of them. And the weight loss was modest here, but what you do see is that there's a disease-free survival and an overall survival difference for patients who were treated with GLP-1 RAs. And so this is pretty provocative, not a randomized study, just a survey, but at least showing that there's a good possibility that using drugs in conjunction with effective strategies might make a difference. And so the weight loss was modest here, and that's consistent with some other data that's come out of Memorial Sloan Kettering. Maybe that's because they're on endocrine therapy. There's an improved all-cause, but not cancer-specific survival, but we'll take that if it's helping these breast cancer patients. So we don't, there's a lot of questions that need to be answered. And I'll finish up with, but I would recommend, and I've started using GLP-1 receptor antagonists in my patients as well if they haven't been offered by their primary care, if they don't have a primary care. And, we have insurance issues for sure, but I think it's an important strategy, and there's been so many other benefits from those drugs as well. So the last thing is about patient-reported outcomes. This was another oral presentation, the PRO-B study, which basically used an intervention of a weekly remote monitoring through smart devices with a survey and patient reports through an app. And then those patients were alerted, those app results were alerted to the healthcare team, and they took care of it versus the standard control group, who had a survey every 3 months. And the primary endpoint was fatigue at 6 months, and the secondary endpoints included survival at 12 months and in different groups. Here's the primary endpoint. By using a remote monitoring, using an app, here there was a significant difference in fatigue. We were able to monitor, if monitoring patients more comprehensively led to a decrease in fatigue. These patients felt better if they used the app and the monitoring. And here you actually see that survival was better too. So 12-month overall survival was statistically improved by 29%, and it was not yet in visceral metastases, but the overall survival there in the whole sample showed a survival benefit from doing that. So I think what that data suggests to us that monitoring our patients for symptoms can make a difference, and we can make them live better lives, healthier lives, even when giving them therapy in the metastatic setting. So it takes a little work to have these systems are available now to monitor these patients. So I think it's an exciting time in breast cancer, de-escalating and escalating when appropriate and being more holistic. So thank you very much.
Thank you, Dr. Schwartzberg. I would like to invite Dr. Iyengar from Memorial Sloan Kettering Cancer Center up to the podium. He will give our next session.
Good morning, everyone. Thank you to the conference organizers for the invitation this morning. I'd like to get right into it, and I've been asked to speak about breast cancer in Black women. And what I'd like to do this morning is present to you some data, epidemiologic data, and also submit to you that we should consider breast cancer in this population as a unique entity that needs unique solutions and perhaps even unique treatment. I'll then show you some data from the San Antonio meeting, 2 studies in particular, which I think add some additional perspective, and then bring it together in terms of how we might incorporate some shifts in our practice to address the unique needs of this population. Now, my own research program focuses on tailoring whole person care during and after breast cancer therapy, and certainly addressing culture-specific needs is a key component of providing engaging care that impacts outcomes. And I'll show some of that here in terms of how we can incorporate that into our whole person care model. And the last thing I'll say is that this, of course, is not my lived experience, and so when I do go to clinic and treat patients in this group, I think it's really important, of course, that we engage in shared decision-making and understanding and how we might be able to address some of those needs. And that kind of conversation with advocates and our own patients is particularly important for informing our treatment paradigm. So with all of that being said, let's just start with some epi, and I think most folks are familiar with this data, but we've known now for some time that while the incidence of breast cancer is higher in the Caucasian or non-Hispanic white population, mortality rates are higher in the Black or African American population. And there's been much research to try and understand what is underlying this potential disparity, whether it's access to screening, access to care, differences in the biology of the disease, other host factors that might be contributing. And so far, we're learning that it's probably
I know,
all
I
of
did
the
the same
above,
thing.
a lot of
I was
these
like, wait, what?
factors that are contributing. And the weight of each factor is what we're still learning about, and I think some of the recent data from San Antonio is helpful in terms of understanding when we prioritize or use biologic differences in the disease to address the treatment plan, when we think about socioeconomic or demographic factors that are contributing, and how we put that all together in terms of a whole person care plan for the patient. So here are some sort of key features, if you will. Again, I think most of us are familiar with these data, but I'd like to highlight, well, I've already highlighted the mortality issue. We do know from studies that have compared primary populations in West Africa, Nigeria versus the African American diaspora, that there appear to be genomic differences, both ancestral gene differences, but also genomic differences in terms of the tumor phenotype that might account for differences in behavior or aggressiveness of the disease. And then you layer on top of that differences in host factors such as comorbidities, as well as socioeconomic issues, access to care, social determinants of health. So this all sort of works together in concert to create, as I mentioned at the very beginning, perhaps what we should consider as a unique entity in this population. And so when we look at how treatment is approached, particularly in minority groups, we of course know that there are disparities in terms of treatment access, but there appears to also be differences in the way that guideline recommendations are implemented. And if you look at some of these statistics here, it appears that the implementation of guideline recommended practice and that disparity might be contributing as well to differences in breast cancer specific mortality in this population. And I thought this study over here was particularly important because, of course, we know that minority populations, including the Black population, are severely underrepresented in clinical trials, particularly the large phase 3 trials that lead to the approval of many of our drugs. And this has significant ramifications, of course, because we know that the adverse effects might be different in this population, and how we approach or treat those adverse effects needs to be culturally specific. We also know, we heard from Dr. Schwartzberg about EPRO assessments, and there have been plenty of PRO studies, which I think, of course, is very important, but we don't have enough data in terms of how those PROs are reported, perhaps differentially in underserved populations and ethnic minorities, and how those PROs might be addressed effectively. And so an area of significant research need is understanding whether or not we actually need to tailor our instruments, the surveys that are used to assess those patient-reported outcomes, to address unique needs in underrepresented populations. And I'll show you some more data shortly with regard to that. So, of course, I mentioned this, these statistics. We do know that outcomes are unfortunately worse in the Black population here, and that seems to be across multiple different endpoints here and multiple different stages. We know that outcomes are worse for localized breast cancer, and metastatic breast cancer as well, and you can see the difference in the 5-year overall survival or relative survival rate at about 83% in the Black population versus 92% in the white population. So again, I think that I've stressed this, but ultimately, in addition to all of the factors that I've mentioned here, access to screening is one that has been investigated and looked at, and we know that culturally tailored models for effective screening can actually move the needle on earlier diagnosis and then translate ultimately to better outcomes in several population-specific studies that have been reported. So this is the theme of what I've been talking about for the last few minutes, and that is essentially that there are multiple factors, and again, I think folks here are familiar with this, but we know that in addition to the socioeconomic or socio-demographic factors and the biologic factors, there are also cultural or historical factors that are important to keep in mind here, not just the migratory patterns or the differences between the primary and diaspora populations, as I mentioned, but also the history of the lived experience of underrepresented populations and understanding how that translates to concerns within the community, such as mistrust of the medical community, but also how this might impact our own implicit bias. And I think that dissecting the layers of systemic bias and our own implicit bias is important, and of course starting with that recognition at the systemic level and even at our own provider level is an important start, and to ask ourselves, am I addressing all of the unique features in this particular patient? I think we of course need to do that for all of our patients, but particularly for groups that have been underrepresented with poor treatment outcomes. So to address this, we saw some interesting data that was presented at the San Antonio meeting recently. So there are two that I would like to highlight here. And this first one speaks to the differences in biologic factors in breast cancer in the Black population here. And so essentially what this study did was an observational study that looked at the biomarker alterations, genomic and others, amongst the Black population with breast cancer versus non-Hispanic white population, as well as how these patients were treated and how that translated to their clinical outcomes. So this was an observational study that used real-world data from the Flatiron Health database, and this allowed the investigators to also take a look at genomic alterations, particularly PIK3CA, AKT1P10 pathway, as well as ESR1 and the BRCA1/2 alterations. And I think this is interesting too because we do see a lot of data, emerging data, indicating that these alterations are different. The prevalence of these alterations are different by race and ethnicity, which of course is important for understanding the biology of the disease, but also our treatment selection and how that may be unique based on race and ethnicity. So in this study, there were over 2,000 patients who were included, with about 12% being Black. And consistent with prior studies, the Black population was younger, had higher grade tumors, was less likely to be some of the more favorable or indolent phenotypes like lobular carcinoma, and also more likely to live in lower socioeconomic areas or to be insured through public insurance. Now, interestingly, and I'll show you this data on the next couple of slides, the genomic alterations also appeared to be different, particularly alterations in PIK3CA, whereby there was less mutation in PIK3CA in the Black population with breast cancer compared to white women. Of course, this is important for the prognosis and the biology of the tumor, but it doesn't explain what you would consider or what you might consider to be the hypothesis. We know that PIK3CA alterations confer worse prognosis in the absence of treatment, and yet these alterations were less likely to be found in Black women, suggesting that even our prognostic factors need to be re-examined because, again, we know that mortality rates in the Black population are higher, so perhaps the genomic landscape and its interactions with all of the other factors that I mentioned are uniquely impacting mortality in a way that we might not expect in the Black population. So 2 take-home points from the data that were presented in this study. One is what I mentioned with regard to the PIK3CA alterations, and also the receipt of standard of care first-line CDK4/6 inhibitor therapy was less common in the Black population versus the white population. Now, the authors speculated multiple different reasons as to why this might be the case, but it could also be that the Black population received more chemotherapy, which might be representative of more triple-negative breast cancers in this population or more aggressive disease in this population. They did multivariate modeling to try and control for those phenotypic differences, the standard phenotypic differences in tumors, and ultimately came to the same conclusion that the use of CDK4/6 inhibitor therapy was less utilized in the Black population, independent of tumor phenotype or other factors that could explain why this might be. And this, of course, all of these factors translated to what the authors observed. It was worse overall survival, which is consistent with the epidemiologic data that we started with. So ultimately, the authors concluded that gene expression differences by race appears to be supported by the findings of this study and is consistent with other studies that have been reported, and that Black individuals were less likely to receive guideline concordant care, and that ultimately this translated to worse overall survival. So ultimately, I think what we're seeing here is not only are there biological differences, but perhaps treatment approaches in this population might be contributing to the worse outcomes in this population. We do have a lot of work to do in terms of understanding the differences in the genomic landscape by different populations here. The predominant number of studies have been done in Caucasian or European populations, and certainly we know that germline genetics differ by race and ethnicity, and it appears that genomics are likely to differ as well. And we also know that epigenetic variation is impacted by multiple factors, including race and ethnicity, but certainly your lived experience and your lived environment as well. So lots of factors here that are interrelated and between both the biology as well as the social factors here. And that ultimately is why considering the social determinants of health is important for every patient that we approach, because this is not only, I think we recognize that this is important in terms of what kinds of resources we anticipate might be a challenge for our patient, but it has very real implications as well on the biology of the disease. And this might impact how we think about treatment sequencing, for example, treatment selection, and so forth, with the caveat that the first priority, of course, is guideline concordant care, but understanding barriers to access or whether or not the biology of the disease itself might be appropriate for the guideline recommendation is particularly important in underrepresented populations. So another study that was presented by Catherine Crew's group, which I thought was quite interesting, was looking at what's called the allostatic load. And the allostatic load is ultimately an index that it helps to quantify physiologic stress on a patient. And it essentially does this by looking at comorbidities, but also looking at other sociodemographic factors that might be contributing those comorbidities. And you can score this. And what the investigators did was they scored the allostatic load across Black and Caucasian patients, and then used a median splits analysis to understand what was considered to be a high allostatic load versus a low allostatic load and how that might impact outcomes here. So when you look first at the allostatic load, what you can see here is that the population that bore the highest allostatic load was the African American population. You can see other races and ethnicities represented there, with the Hispanic population as the second highest allostatic load. And so we know from these data that at baseline, these patients are coming in with additional comorbidities, but not just comorbidities to consider, but the sociodemographic factors that are perhaps contributing to those additional comorbidities. When you look at the factors that are associated with allostatic load, race, of course, and being non-Hispanic Black, as I mentioned, was associated with higher allostatic load. Interestingly, what came out of this population as well, or what came out of this study as well, is that regular exercise was inversely correlated with the allostatic load. And that's, you might expect that. Of course, we know that exercise is associated with a reduction in comorbidities and improvements in overall survival. But reassuring or nice to see that even in populations that are dealing with a high degree of comorbidities and other factors that are dampening their health outcomes, exercise remains to have a positive effect in that population. Although a study that I'm not showing you here that was presented in the same poster discussion section was a study looking at rates of physical activity by race and ethnicity, particularly in breast cancer survivors. And that study reported that not only is our physical activity levels lower in the Black and Hispanic populations, which has been previously reported, but it appears that the availability of physical activity counseling programs are also lower in underrepresented populations as well. And so there appears to be an access issue for our supportive and whole person care programs as well. So really a major priority is getting more access to those programs for our underrepresented individuals, because we know from these data and other studies that those types of lifestyle interventions might be particularly important for the Black and Hispanic populations here. A high allostatic load was also associated with a more aggressive disease, again, as you might expect, given other comorbidities like diabetes that can contribute to worse breast cancer outcomes. So the investigators concluded essentially everything that I've just mentioned here, and that further research needs to understand how a high allostatic load translates with breast cancer outcomes and how we might be able to mediate that relationship by intervention. So I'll spend the last few minutes now shifting toward how we can take that understanding into our clinical practice and implement perhaps a unique care paradigm. And I think, of course, what we really need to do is understand when we're talking about clinical trials, how to recruit patients and represent patients that are underrepresented in our clinical trials, because in my opinion, that's really sort of at the base of the problem here. If we can get more representation in our clinical trials, then we'll have more concrete data in terms of how to address those biological differences. Right now, a lot of it is done through extrapolation from non-representative populations here. And so there have been several guidelines or recommendations that have been published in terms of how to recruit underrepresented populations into clinical trials. And I think ultimately it really comes down to making a concerted effort, being present in the community, and having community allies and partners that we can work with, not only to establish trust, but really to communicate in a way that engages with patients of different populations here, and to really emphasize the importance of getting these folks into our trials. Now, we also know that many of our clinical trials are built in a way that establish barriers for underrepresented populations to participate. And this could be travel to a center, but this could also be eligibility criteria that may be uniquely imposing a barrier on underrepresented populations here. And so I know that our IRB and many other IRBs now do a specific review of eligibility criteria to make sure that we're not implicitly imposing biased selection criteria based on multiple factors. So I think it's a combination not only of recruiting and partnering with advocates in the community, but also making sure that we're building our trials in a way that foster participation from underrepresented groups. Now, in terms of how we approach treatment, of course, guideline-directed care is a key priority here. And I think essentially based on data that was reported at San Antonio, which I just showed you, and multiple other studies showing decreased or a lower prevalence of guideline-directed care in underrepresented communities, more research is really trying to gauge or understand why that might be the case, whether it's implicit bias versus resources versus access versus the disease characteristics. And I think that will help inform what our approach is to try to improve outcomes by matching the guideline-directed care to our underrepresented communities here. But again, in my opinion, I think it does come back to we really need to build the research in these populations here, because even the guideline-directed care has predominantly been established in European and Caucasian populations, and we need to understand from dedicated clinical trials that address minority populations whether or not our treatment approach should be tweaked or modified in a way that matches the unique factors of that population. So that ultimately brings us to the concept of patient-centered care, which I think has been a really important theme of the San Antonio meeting and many of our meetings now, where we really need to understand all of the factors that are contributing not only to the way that the disease itself behaves, but how our patients may respond, both from and not only from an accessibility standpoint, but also from an adherence standpoint, from a feasibility standpoint, and how our therapies may actually impact the breast cancer itself. This is, for now, what I would say the most important way to address those needs is really shared decision-making. And these are some key features of shared decision-making. I think many of us are quite familiar with these features here. But again, emphasizing research, particularly into the non-biological reasons as to why outcomes are worse in this population, is going to be important for helping us deliver this sort of shared decision-making care here. And these are the components. A lot has been written about shared decision-making. I think commonly it's well, maybe not commonly, but I think a knee-jerk reaction to shared decision-making is that, oh, okay, the patient comes in and say they read something on Google or WebMD, and now I have to prescribe it for them. And I think, obviously it's a lot more complex than that, and it's really presenting the treatment options and your recommendations to the patient, but then understanding what factors the patient is dealing with and how that might modify your treatment recommendations, and then ultimately coming up with a plan that delivers the optimal care, but delivers it in a way that is feasible and palatable to the patient and addresses their goals and their needs. So I'll leave you with some additional resources here that I think are particularly helpful for our patients, but can also be helpful for clinicians as well. And I'll thank you for your time.
Before I invite our next speaker up, I did just want to touch base on our CVent app. I know some of you have come up and let me know that you're not able to access the slides. I would like to encourage you to go to the hamburger lines at the top, log out of your app, and re-log back in. Sometimes it has a lag if you stay logged in between each conference that we put on. So if you'll log out and log back in, enter your code that you receive in your email address, you should be able to access all of the slides at that point. I apologize for that delay. At this time, I would like to invite Dr. Mehta from MD Anderson Cancer Center up to the podium to present our next session. Please join me in welcoming him.
All right, thank you. I was looking out here, and in the spirit of this conversation around integrative medicine and the risk of disinformation, I think I'm going to say that there are thousands of people here. So this is obviously a broad topic. I think everyone can kind of sit back here. We have about 20 minutes, and I think I'm holding you from the break. So we'll talk about how integrative medicine, lifestyle impacts cancer outcomes. There's a lot here. Each of these things we can go into sort of specifically, but we'll stay fairly broad. So when we think about outcomes, we're thinking about survivors, not these survivors. FYI. I think Survivor's in its 30th season, or maybe more than that. We're obviously talking about these folks. And the reason, I think we all know, we see a lot of cancer, and we know that there's lots of reasons for this increase in incidence and prevalence, and which one is it? And there's an increase in just awareness of cancer, specifically certain cancers. So I'm a medical oncologist. I primarily treat breast cancer for the last 20 years. I work part-time now. But in breast cancer, there's a ton of awareness. And so women are getting mammograms, not as much as they're supposed to necessarily, but but they're getting them. And then there's just more people being diagnosed from incidental testing. The treatments are getting better, so more people are being cured of cancer. Our metastatic patients, as you know, particularly in diseases like breast cancer, certain hematologic cancers, they're just living a lot longer with their disease. So it creates this large burden on the system in terms of managing patients. This is the current estimate of cancer survivors. In about 10 years, we're looking at 25 million cancer survivors. This is non-skin, includes melanoma, but non-melanomatous skin cancer is excluded in these. So when I think about health, as an oncologist, and really everyone here is a healthcare professional, our training, as we know, as a medical oncologist, we did 10 years of training, and I think we all know that there was very little, if any, on health. We learned a lot about disease because we have to learn a lot about disease. And it's important to understand, to diagnose it and treat it and manage it, but health is something we really don't know very well. Yet, as the healthcare professionals, we're the ones responsible. And it's a scary thing when every commercial says, ask your doctor about exercise and nutrition. I think most of us know the dirty little secret. We don't really know that much about it. So this statement from the World Health Organization, this is from 1946, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I think that kind of sums up health for all of us, but it's a nice summary. And when we think about health in the cancer perspective, we have to be careful. Our patients sometimes believe that that's a normal PET scan, so you're cancer-free, theoretically. But does cancer-free really mean healthy? And I think we all know that often it doesn't, particularly because of the treatments and the ravages of the various treatments we give. I thought I'd just put up here that integrative medicine is under the auspices of the government, which I'll talk about here, but the Health and Human Services, the Secretary of Health and Human Services is now, I'm not going to comment, the Secretary of Health and Human Services, but HHS has several departments, and one of which is the NIH, and the NIH has about 24 institutes, one of which is currently called the National Center for Complementary and Integrative Health. That used to be called the National Center for Complementary and Alternative Medicine. So alternative has become a taboo term because alternative implies you're doing something in lieu of standard of care. Integrative means you're doing it alongside conventional care. That's the current director of the NCCIH. She's a researcher who works on connective tissue research and has done a lot in the acupuncture world. And their current budget is about 180 million. So there are many grants that can be applied for through there. So what is integrative and complementary medicine? So obviously we're not going to go into all of these in detail, but it really means a lot of this and more than this. Nutrition, obviously, physical activity, mindful movement, natural products, sleep hygiene, mind-body practices, even psychosocial practices. Narrative medicine is an interesting one that I think several institutions now have a division of narrative medicine, journaling, gratitude, all of this. Particularly in the stress of the last 5 years, there's been more and more attention being paid to this, both from a provider standpoint and particularly from a patient standpoint. But I can't not mention this issue. It sounds like he's Alberto Brandolini. This was about 15 years ago, so it's not some statement from the 1800s. But the amount of energy necessary to refute blank is an order of magnitude bigger than to produce it. So another way to say it is, a lie goes around the world faster than the truth has a chance to tie its shoes. So we know that misinformation and disinformation is a big problem. I think it's making our lives as providers that much more difficult. I think it's contributing to provider burnout. But there's the other sort of competing narrative and that's Carl Sagan over there, but the absence of evidence is not the evidence of absence. So just because you don't have evidence of something doesn't mean it doesn't work. And so we do need more studies. But Dr. Iyengar mentioned, that there is this issue of information, misinformation, disinformation. what's going on here is, it fundamentally is this issue of dilution of expertise. And I think we're all guilty of it. We want to be humble about this, that, I thought I could change my toilet a few months ago, and I should have called a plumber because it didn't work out too well. But our patients think they can read for a couple of weeks and know what there is to know. And of course, when they're reading, they're Google searching and then going down a rabbit hole. So this is a problem, and I think it needs to be dealt with at a very large scale and at an individual practice and practitioner scale. Social media algorithms, that's its own issue. But it leads to these issues of tribalism and confirmation bias, et cetera. So the NCCN, about 11 years ago, started their survivorship, survivorship guidelines. It was actually started by Dr. Crystal Denlinger, who was a fellow with me, who's the current head of the NCCN. So she really believes in the idea of survivorship. Now, survivorship is far more than healthy lifestyle. It includes all of the late effects and early effects of treatment and all of that. But in the survivorship guidelines, there is an entire subcommittee on healthy lifestyles. And there's a lot of really great folks who are involved in that. This is a quick summary of the NCCN survivorship guidelines. They do go into a lot more detail in the guidelines itself and the data behind it. Healthy body weight is an interesting one. This is evolving. So if some of us remember, it was about 20 years ago when the BMI guidelines changed, and overnight, millions of people became overweight because they cut 27, they pushed back what overweight is down to 27.5 when it used to be 30, and now 30 is obese. But there is this new index that's being thrown around. It's complicated. I don't like the name of it. It's called the Body Roundness Index. They got to come up with something better.
I know.
Than this. But the data behind it is actually really interesting. So avoid being sedentary. Unfortunately, we're all doing that right now. The sitting disease is a term coined by the American Cancer Society. There was a huge study about a decade or so ago looking at it. It was about 125,000 volunteers, healthy folks, following their activity levels. And what was interesting, and looking at mortality from cardiovascular disease and cancer, and what was interesting about the study was that those who had more than 6 hours of some activity did far better than those who had less than 3, but even if you had less than 3, you could not make it up with exercise. So the folks who sit all day at work and then go work out 2-3 times a week, probably not the best in terms of for this sort of longer, longitudinal data. Physical activity, you can see the guidelines there. Nutrition, that's a whole other conversation around plant-based foods. By the way, plant-based does not just mean vegetarian. Certainly doesn't mean vegan. No evidence for vegan diets necessarily in the cancer space. Minimal to no alcohol, sun safety, sleep hygiene, all of these things are in the NCCN guidelines. Exercise, that is so I was a personal trainer before I was a physician for a couple of years. And that was, even though that's not my gym, that was very similar to the experience I had, which was that I would have clients come in. It was a 6-story gym in New York City. And I would have clients come in who would take the elevator up to the 4th floor to then go on the Stairmaster and exercise. But so it's about a lifestyle. That's how we have to think of this. And that's how we have to, when we're advising our patients about this, this is how we have to say it. We can't just say go exercise, because obviously that can mean a lot of different things to a lot of different people. But it is activity requiring physical effort carried out to sustain or improve health. That's exercise. 3 main types of exercise that, if we have time in our visits to mention: resistance exercise, cardiovascular exercise, flexibility. Those are the big ones. I would almost consider adding a 4th, which is balance and coordination. There's a field of physical therapy that looks at this. A lot of our patients are suffering from neuropathy and balance issues and falls, particularly the older folks. But that's your sort of 3 main types of exercise we should be talking about. But we can do exercise at any time, and even during treatment. My patients on chemo, I talk about exercise, but when you're on treatment, you obviously want to be more careful around electrolytes and volume status. And And I try to educate the patients about this too, about what to look, because now patients have access to everything. As I just got a message while I was here from a patient on my note from this week that one of the words was wrong. So they have access to everything. So if they're going to have access, we should educate them about what they're actually looking at. But be careful, especially in our metastatic patients around bone metastases, and then I mentioned neuropathy and balance. Nutrition, the AICR, American Institute of Cancer Research, has a great website. I direct patients to it. They have another section in this, it's called a New American Plate. So if we all remember the food pyramid from many years ago, where the carbs at the bottom, lots and lots of carbs at the bottom. We know that's not the right way to do it today. But the New American Plate is again, a great thing to give to patients. This is their AICR's foods that fight cancer. And they have data on each on what sort of ingredients and sort of the phytonutrients and what they do. And so if you want to educate yourself, great website, great information. I'll talk a little bit more about this because I think if you think about what's controversial in integrative medicine, most no one in healthcare is going to argue when our patients want to eat well, exercise, do some mindfulness, acupuncture even. There's good evidence and we don't mind. It's this stuff, supplements. Now, that's what gets us. When patients start, a lot of my patients do, specifically because I'll often see patients who are a little more interested in the integrative space. But when patients pull out their list of supplements, it can be daunting for us because we don't know. And so we often just tell folks to stop everything, which can certainly be the safe thing when they're on treatment. But what about when they're not on treatment? What do we tell them? Who should they go to? And I think if we don't educate a little bit, you create this void, and then where do they go? The rabbit hole, and then all these other practitioners out there that are just predatory and waiting for them. So this, not sure anyone knows who this is. Her name is Yu Tu. She was, in the late 60s, Chairman Mao, so President Ho Chi Minh of North Vietnam asked Chairman Mao to help because his troops were being decimated in the jungles of North Vietnam from malaria. And so they convened this secret military commission, 523 it was called, and she was chosen as the head of this commission to research products to treat malaria. And the species there is falciparum, which is the deadliest of the species of malaria. And they looked at 2,000 different compounds, and what they did is they translated this text. It's a 1,600-year-old text, Chinese text, that loosely translates to emergency prescriptions up one sleeve. And in it, there was mention of a plant, which is known as the wormwood plant. And she and her team figured out how to extract whatever it was because they found out the wormwood plant was helping with these fevers, these relapsing fevers illness. And so they figured out you didn't boil it, you kind of slowly put it in warm water, et cetera, et cetera. And the compound artemisinin was developed, which became, I think it's the current iteration. I forget the current iteration, but it's but artemisinin is still the most effective treatment for malaria, and she won the Nobel Prize, I think exactly 10 years ago for it. So she's neither MD nor PhD, but so natural products are still helpful. We know from our world of chemotherapy that drugs like Taxol and Topicide, and these are from natural products. Although we're not cutting down yew trees anymore, we synthesize paclitaxel. But when it comes to supplements, so about 30 years ago, this act was passed, which is the Dietary Supplement Health and Education Act, which said that supplements were not going to be regulated like drugs, they're regulated like food. That became a problem because then the industry really started to grow. The FDA cannot approve them. And the interesting thing here is about the principle of harm. In the US, the way it works versus in the EU is that you have, the onus is on the company to prove harm. So you can imagine that's not a lot of incentive for a company to do those sorts of studies. Versus in the EU, the assumption when a chemical is put out there, or whatever is put out there, is it's assumed to be harmful, and the onus is on the company to prove safety. And I think that's a big difference in the default of how we, unfortunately, how we do supplements in this country. So when our patients come to us with supplements, what can we say? I think a simple thing is this. This is, it's a wild, wild west of supplements. Patients are taking vitamin D. There's 5,000 brands probably of vitamin D out there. So how do you know that what's on the bottle label is what's in the bottle? Because you would be surprised how disparate sometimes that can be, the dose that's labeled versus the dose in the bottle. So these three organizations, the U.S. Pharmacopoeia, the National Science Foundation, and Consumer Labs, independent organizations, the supplement manufacturer has to voluntarily submit their products, so it's voluntary, to then get this label. So if you see the supplements with this label, at least you know the dose is correct and that there's no contaminants, because again, contaminants are also a problem with supplements. So simple thing to say, I tell patients, if they're taking their vitamin D, do not spend an arm and a leg, because you do not need to. And in terms of data, there's some large studies. This is one of the largest, the VITAL trial. The VITAL trial was published about 5 years ago, 6 years ago, in the New England Journal of Medicine. So the VITAL trial was looking at 25,000 healthy men and women over the age of 50, and looking at the incidence of cancer and cardiovascular disease with 2,000 units of vitamin D daily and omega-3s. It was 1,000 of omega-3, a gram of omega-3 fatty acids. So 2x2 design. And the final analysis did not show a benefit. So we could say the case is closed on that, though I think a lot of folks who look at this, when you really look at studies like this, I'm not so sure the case is necessarily closed. And that's because, even as the investigators discussed, there's a lot of limitations with trials like this. Doses. So, most of the studies with omega-3s looking at cardiovascular disease, for example, use higher doses. Vitamin D, taking vitamin D without measuring levels is like taking a blood pressure medicine without measuring your blood pressure. It just doesn't, we know you need normal levels, so how do you know what dose you need to get at least up to normal of 30 to 40 range? The median age was 67, and these were healthy folks. So if you think about it from a cancer perspective, median age of cancer is about 64, I think, currently, which means these patients have mostly passed their cancer risk already. So looking at cancer mortality doesn't make sense. You should be looking at younger folks and watching them over a much longer period of time, 5 years. I think this is a great effort to do something like this, to put this out there. But, these are, follow-up of 5 years probably is not enough. Adherence was good, but then there was a lot of confounding other supplements that patients were taking. And remember, our patients sometimes think cancer is cancer, but there was some signals around prostate cancer, colorectal, and I believe breast, around some benefits that needed to be looked at. So in the last 18 seconds, good timing. So this is just a humility slide. Like, as practitioners, we sometimes think we know everything, and if you recall, not that I wasn't alive during this time, but this is what, we used to think, and the healthcare, community used to promote. So thank you.
Thank you for that fantastic presentation. At this time, we are going to break for breakfast. We have breakfast set up in the exhibitor room. If you'd like to make your plate, mingle with some exhibitors, and head on back, we will have our non-CME session sponsored by Pfizer. Thanks so much.
Stretch our legs. Oh, no, I'm not a bacon eater. Oof. But, oops, I'm spilling water. Hi, how's it going? You good? Okay. I saw that, but that's okay. A little rock and roll. It's been good, though. Oh, good. Well, I'm not a bacon eater, but I'm kind of I don't want to say pescatarian. Well, I make bacon for my husband, but I'm more of like a I don't know. I like things that swim and things on two legs.
Fish is my favorite.
Yes. Oops.
I'm sorry.
Hi. Oh, thank you.
Doing the Google thing, trying to figure out where you bought
So, you know what? I got this at a secondhand store in Tokyo. Well, and Tokyo is very interesting in fashion of like, they put tulle on top of everything. So like you'll see a lot of their younger women, I mean, their business attire is very simple, but like in their fun attire, there's not like people think it's the baby doll. It's really not. It's like you'll see jeans with like a tulle skirt or like a long sleeved white button down with like a cute corset. So anyway, we were there and yeah, it was,